Hello, everyone. Good afternoon, good morning, wherever you are. My name is Bob Miglani. I am so delighted to be with you today. We're live streaming with Dr. Joelle Holland. Hi, Dr. Holland.
Hi.
Is these like jazz hands? Are we
I
doing
know,
jazz hands?
jazz hands.
So nice to see you, Dr. Holland. Thank you for making the time. Hello, everyone. Whether you're watching this live or you're watching this later on, we're so delighted that you picked us in your busy day to view something really important. We're here to help you navigate your journey of specializing in a treatment, is providing services to patients that are really valuable for them and for you as you grow your clinic into more niche and specialty care. So my name is Bob Miglani. I'm the founder and CEO of Hoot. My wife is a doctor. That's how I got into this business. I was pulled into this kind of business. And I'm delighted that Dr. Holland is here with us. She's an expert on dry eye disease. What makes her an expert? She's been doing it a while. That's how you become an expert. You don't go to school for dry eyes, do we, Dr. Holland? We try it.
No.
No, we don't go to school for it. So as we begin today, Dr. Holland, just tell us a little bit about you, about your journey into specialty care, because you're an optometrist and you could have gone the path of, hey, let me just do primary optometry, but you chose not to do that and pivot a little bit. So talk to us about your journey, Dr. Holland. Thank you so much.
Sure. Well, yeah, thanks, Bob, for inviting me on here. This is kind of neat. So, okay, so I am Joelle Holland. I practice up in Medina, Minnesota, and I'm sitting in our dry eye suite right now, which definitely did not used to look like this. It was like a tiny little closet of a room 9 years ago when we purchased the LipiFlow, and that's all we had. And so it's expanded since then. I'm an associate optometrist at Complete Eye Care of Medina, and I joined the practice, and Gina Wesley's always been kind of an innovator in trying to new technologies, new things, all the stuff. And that was the first thing that she brought in. And so I started learning more about that. I'm sure we touched on meibomian glands in school, but if I actually remember talking about that, I don't think so. And so, coming out of school, all I really knew was, insurance exams and how to do a refraction and all that stuff. And this was just a totally different world. So, it was pretty disconjointed. I feel like we didn't really have a protocol. We didn't have all the things. We didn't have all the people, the words, the speeches, the elevator pitches, the pricing, all the things. But we did have that machine, and we knew it worked. And so we started with LipiFlow treatments, and we did that. We did a ton of those, and we I feel like every 6 weeks or 8 weeks, we'd be tailoring our protocol. We'd be like, okay, well, that ocular surface conversation didn't go well, so let's try to do this. Okay, now we're doing way too much and we're losing the patient and they have no idea what we're talking about. Let's scale it down. Okay, now they have no idea what we're talking about. We need to expand. So it's always this trial and error on what works, what clicks, and everybody's clinic experience, patient clientele, everyone's different. And so I feel like it's not super cookie cutter, which I love because you can expand it within your own place. But as we've gone on, we've just really truly loved what we've done in the dry eye space. We love that it is the majority of it is a cash pay niche. And so that's a huge practice builder. And that's also something that I really love because yes, it may be cash pay, but a lot of these treatments in here are treating root causes of what's going on and not just topical symptoms. So I really love that part of the holistic, deep-rooted, integrated science, healthcare of the eye care field. So, yeah, I feel like we've really grown. We've acquired a lot more instruments, and we're continuing to acquire more instruments. But our path has definitely changed as we've gone. And so
Amazing. So thank you for that. So let me just step back for a second. Let's peel it back a little bit. So you decided to go into it because you saw patients have this problem and it was a serious problem and you wanted the tools, the treatment tools to help provide it to them. The problem was that, as I see it, is that this is out of pocket. Insurance doesn't cover it. And so you really have to think differently about how you approach conversations. So tell me a little bit about the early conversations you would have with patients. Like the patient comes in, you're giving them an eye exam, they have, you're diagnosing them with the condition. And then, like, are you nervous? Because the money must be on top of your mind. Like this patient's this is out of pocket. It's, this much money. So what do I say? Is that like, tell me about your mindset of trying to understand how to communicate with that patient, a very complex problem in just one sitting, because they just come in for an eye exam, right? And then here you're talking about MGD and all this other stuff. So tell me about like how you think about that.
Right. So I'll say like when we first started, I think we did have we had the Lippy scan that went with the LipiFlow.
Okay.
And we didn't have like a separate meibographer or anything, but we had that, and we would like run these like reports. It'd be like the tear film and the this and the breakup and all this stuff. And we try to incorporate that like in our eye exam when we saw that their glands weren't functioning, because I'm using the MGD like little applicator, and I'm telling patients, oh, there's not oil coming out of your oil glands. And they basically were like, I have no idea really what you're talking about. And they couldn't even like put it into like context. And I would like be verbally explaining it, and it didn't make really any sort of sense. And so I think that was the first pivotal moment of being like, I think we need a separate exam to like talk to them about this, but they need to be able to see it in the exam room, because that's a problem. And so, or to like understand what the problem is. And so I guess I can kind of like jump. What we do now is we take a picture of their eyelid margin to show telangiectasia, and then we take a picture of their meibography to show any atrophy. And we just do one single lower eyelid in every exam, everybody's exam. And as I'm pushing on the glands, like I know that this is a problem. I can see that there's no oil coming out. And then there's a whole division of like, are they symptomatic or are they not symptomatic? Because if they're coming in with a complaint, the conversation is way easier to have than when they're coming in without the complaint. Right. So now we show them the lid inflammation and the gland dropout. And we say, what I can see behind the microscope is that there's no toothpaste coming out of your toothpaste dispenser. Like it's just, it's stenosed, nothing's happening. Yeah. And we think it's due to this inflammation that's causing this dropout that you can see in these photos. And this is a problem. And if we don't get a handle on this problem, if they have symptoms, I'm going to say your symptoms are going to keep getting worse. Like this is part of your problem. Right. And if they don't have the symptoms, I'm like, hey, this is kind of like finding like decay on a tooth before you have the cavity. Totally. Or before the pain starts coming in. Like we can do something about it before it becomes a big problem. Yeah. And so then that's when we're moving into like, okay, let's get you back for this evaluation where we can talk about all this stuff more. And I have even more testing that I can do to really make sure I have all the pieces of the onion at least somewhat understood, because dry eye is like that onion. It's like, I can see a lot of things happening right now. I have no idea which one is causing you the symptoms that you have. Right. And so I'm going to start with the biggest one, the one that the studies tell us is probably going to help your symptoms the most. Yes. I can see all that lid inflammation. I can see all this stuff. So we'll start there. But as this onion starts to be peeled back, I don't know which layer is connected to your symptoms. Right. And so we're going to keep working on it. And that might mean we're on therapeutic eye drops or a nasal spray or like a lacquer fill, or like, so maybe that requires something else outside of like these instruments. And when I have the conversation about money, I'm like, some of these things are out of pocket. Some of these things we can run through insurance, but I don't even know which thing is causing you your problem. Right. So we need to have you come back to actually see what that is.
I love that. I love that. So let me just pause for a second. There's a lot to cover here. First of all, I think, one of the things that you're doing is spending some time to diagnosing the condition with an objective assessment, which is a meibography. Okay. A lot of doctors don't do that. And then it's, because patients today, I think more and more want proof, right? They're like, show me the stuff, show me. They're used to going to the dentist and getting a scan, getting an x-ray. So I think that's really powerful. Would your strategies be as effective if you didn't do pictures and meibography, Dr. Holland?
I I really don't think so. I feel like we live in a culture that I agree that's like if I don't feel like if I feel it, maybe that would be something different. Like if my eyes hurt and then I'm like I can see this. But we live in a culture that people do want proof, and it's super simple. We just do a screening, and so people are like, "Why do you only do the screening?" Because like 99% of the time, both eyes are the same, and this is just our screening. We'll do more at the evaluation. So come back and we will scan all the lids, and we'll make sure everything looks okay.
Yeah. Right.
But absolutely, I think they need the proof.
Yeah. I think the second thing you're doing really well is educating them about the problem. The biggest mistake I see, doctors make initially, they got that patient in the chair and they're so in love with their IPL, RF, their device that they start talking treatment right away. They're like, hey, I've just diagnosed you. I am so happy I caught this. Amazing. And by the way, there's this amazing tool. And the patient's like, are you trying to sell me something? Mm-hmm. Right. So I love that you're spending time educating them, because doctors often think I need to do marketing better. No, you need to do education better, because that is what we have lost today in a hurried culture, right? The doctor and the patients both don't have time, and you're being pulled away. And what we want to do is we think the bridge really is the education that you do. And so the way you're doing education is explaining this to them. Say, look, I've diagnosed your problem. It's concerning to me. You're saying all the right words. And they're saying, I think this could be this, that, and the other, but let's have you come back, versus like cramming that comprehensive exam. Mm-hmm. And I'm sure when you've, in the past, and you've, done that, which is cramming that comprehensive, they're like, what is going on? It's too much, probably deer in headlights, right?
Yeah, totally. And I don't like cutting short my refraction or like my conversation about glasses, because then that hinders your optical. And I don't like cutting short like my retina exam, because then they don't think you're a real doctor. And then, so I don't like doing that. I like my comprehensive is my comprehensive. And I'm also seeing this as a problem. So I need to have you come back. I do like to let them in when they're waiting to come back. I do love to be like, okay, here's 4 things I want you to start at home. Here's some videos you'll receive on just taking care of this at home. Try this first and let's reevaluate. Let's see if that does anything at home. And so like they're doing their maintenance at home, which will probably help a little bit. Yeah. But then when they come back, people, I've found the longer that I've done it, like they want something to do. Like if you just tell them, you're like, you need IPL, period. You're like, well, you didn't even try an eye drop. And although eye drops, like everybody thinks you got to start with an eye drop, even a prescription eye drop, but I swear, I think this is kind of like the more recent stuff that I've started to like move into. Even if I start a prior authorization for like a nasal spray and I give them a sample, like to them and their brains, they're like, okay, like we're trying something, we're doing something. And then they get that whole crazy PA experience and they don't know what's happening and everything's $9 million. And it's like, okay, then they get to the ocular surface evaluation. Like, well, we tried some of that stuff. It's going to be impossible to work with your insurance to do that. That's how insurance works.
Yes.
They've already kind of experienced some of that, like muddled, this is annoying, I can't even communicate with that. And then now they're ready to hear other options that don't involve their insurance. So I found recently that that's been pretty interesting, and giving them time. Like they also don't want to be like rushed into something. So like, well, why don't you start this and I'll see you back in 4 to 6 weeks and we'll see how that works. And we'll try to run some things through your insurance and we'll see how that works. My staff is kind of communicating with them as those weeks go on, and then they're ready. Like they're ready to come in and like hear what other options they can have.
Yeah. So I love that. So it's kind of like, I suppose, you go to your doctor and they say, hey, Bob, you've got cholesterol, and here's a prescription for Lipitor or whatever, statin, and it's like, don't you want me to like work out? Like, don't you want me to exercise?
Yeah.
Bob, how many burgers you're eating, right? It's like, hey, you got to like do some things at home, Bob, the patient, so that it's your responsibility as a human being to take care of your gut and your food and your nutrition and all that, because that does play a role. Yes, of course, I'm going to be a terribly non-compliant patient. I'm not going to listen to my doctor. The cheeseburgers are really good, but at least my doctor told me.
Yeah.
And I feel more the credibility in my eyes of Dr. Holland telling me, okay, you got to try these things. Like, please reduce your screen time because you're looking at screens way too much. Try the warm compress, try this, let's try omega-3s or whatever. And then let's come back and see you. Because
Yep.
so you're right. I think there's a prescription that the patient has to follow about behaviors at home.
Yeah.
Which indicate that the doctor did something for me. We're just
And
so
I think
used to
it's
that.
like when it is hard to be like, yeah, I got to fit all 4 of these things in my routine every single day. When I'm like, so how did that go? They're like, well, I probably did it like 10% of the time. I'm like, I know, right? Like I even say, like, I know it's challenging for me to do that stuff too. That's why, if you want to invest in getting better, reversing some of the stuff that's going on without having to do as much of that stuff at home, it's still important to do at home. But if you don't want to be like hogtied to the routine, like these things are options, and
Yes.
that's what we talk about.
So let's switch gears a little bit. Let's talk about conversion. Let's talk about, so they come back for an ocular surface evaluation, which is, so have you found, so first of all, when you do that education mode, do the meibography, do all of that, and then, give them some things to do at home, and then having them come back for a follow-up. Have you found that your conversion, that more people signed up for your treatment versus, cramming the comprehensive and not doing that?
Yeah. I think recently, yes, because I would say it's only been probably the last maybe 3 months, 4 months that we really tried to start reverting back to having them come back for the evaluation. Because I was like cocky and I was like, I can do this all in my exam. Like, why would I want them to come back? And I can have all these conversations. But we've got Neuralens and we've got ERGs and we've got like all these other things that like I'm trying to get in the comprehensive exam. I'm like, this is ridiculous. Like how much stuff I'm throwing at them right now.
Right.
And so now I really think that when they try things, they're communicated with at home, like in between, they're receiving something in between that like is connecting the dots a little bit more. When they come, they are definitely more apt to converting. And sometimes it's just more time. It's like, because maybe I'll run Inflammadry at that ocular surface evaluation or Tear Lab or something. And I'm like, you know what? Like, I think we need to, whatever, like do a pred and do Lacrophil and then see you back in 3 months and see. So I'm really trying to stay away from like being as cookie cutter as I think I was prior to being like, if I see red, I do IPL. If I see this, I do this. And really bringing the patient into that conversation and being like, because this is so multifactorial, we need to look at all these pieces and see where we need to start first and build a plan off of that. And I think when they start to see that you are actively trying to like put their puzzle together, when we finally get to like the cost of what IPL and RF and LLT and 3 meiboflows is going to be, they're going to be like, oh, okay, like this makes a little bit more sense than just being spit at that and then being like, oh, and by the way, you owe $1,200 for pair.
Right. It's like, the money. It goes on. I think that's a good way to think about it, is that, so, when you've switched to this new way to do things, also, have you found the quality of life for you as a doctor, as a person, has become better, that you're not rushed and that, you're seeing more high value patients? Have you seen the quality of life improve in that sense?
Oh, 100%. Because I really struggled, I think, with like not giving them all the answers at once. I feel like as optometrists, we're very like people pleasing. And we're like, we just want to make you like understand all the things and share all of our knowledge and time and not feel like we deserve anything in return. And that just like wears, because then you're 3 patients behind and the staff is mad at you and the next 3 patients are mad at you and they don't want to hear anything you have to say because they just want to get out of here.
Right.
And so I think once I've finally been like, this is your comprehensive eye exam. Like, we are going to tip of the iceberg all of the things that we need to talk about, and then we'll put all that together throughout the year. And once I stepped back from that, I really think I was like, okay, like I'm taking care of this problem today. I'm taking care of that problem tomorrow. And if they decide not to come back, that's not my problem. I'm like, we'll try to follow up with them, but like, this is how it needs to be. Like, if I'm going to take good care of you, routine comprehensive care of you, it needs to go in segments like that.
Yeah, no, I love that. And I think, a lot of times, doctors feel rushed to just explain everything to them.
Mm-hmm.
And the answer is that the more if you confuse, you lose.
Yeah.
And so people are drawn to clarity. And most of the time, honestly, they'll do anything if they trust the doctor, like the doctor, and think the doctor is going to solve the problem that they have.
Yeah.
And so actually saying fewer things can be more powerful than saying all this other thing, because you're like confusing them to a point of like they get stuck. Yeah. It's like, you do this. I had this great, we have a dentist. I took my youngest child to a dentist. I think I mentioned the story to you before, last year. And for the first time, okay, I felt so guilty, first of all. I took him, my wife was traveling. And so we go to the dentist, and dentist is saying, Mr. Miglani, your son has 9 cavities. I'm like, oh my God. And I'm like rushed. And she's dancing around, explaining to me what to do.
Yeah.
Okay. Because I'm like, let me call my wife. What am I supposed to do? I have no idea. And so she's like dancing around. And I'm like, Dr. Kaur, I'm like, please, I trust you. Here's my credit card and tell me what I need to do.
Yeah.
Like, just make it clear what you wish for me to do. Because once that trust is established, patients are like, I don't need all this. I have too many words in my head from social media feeding me, my kids, my work, all this stuff, my colleagues, all this stuff. I trust you, but it's got to be, but that trust has to be earned.
Yeah.
And that trust initially, I think it is where you're diagnosing the condition, you're educating them enough that they feel somewhat like, yeah, I think this kind of makes sense. I'm with it. And then they're like, yes, I'll do anything you ask me to, Dr. Holland, because go, like, let's go. Find that trust, creating that trust is very important.
Absolutely. I mean, I think with how we are fed, how you said, we are fed so much information, and especially now with like the dawn of AI, it's like you watch, you're like, I don't even know if that is coming out of that person's mouth and they even know it on social. Like, they're just like AIing someone's face talking about some product or something. So I think all of us are feeling that. And when you've had a patient, especially a long time established patient, or a patient that gets referred into you, clearly someone's already talked to you, whether they saw you online or somebody referred one of their doctors referred you into our clinic. There's already a little bit of trust there because they've come to you for many years. They're new to your clinic because they saw you do these services online, or somebody already referred you. There's already a little bit of trust there. So building upon that trust shouldn't be super difficult. Yeah. But I read a book, Story Brand by Don Miller. He just like nailed it. It's like the less you say, the less cluttered things are. That's the only way anybody's going to understand what you want for them, because we all are trying to do good for them. But the more that you say to them, they just think you want a new boat, and you're like, well, that's truly not what, and that's not even going to get me a new boat anymore. But like, that's not what I want. Like, I really enjoy taking care of patients like this. Yeah. And so I want to build that trust. And something on that AI front that I just started doing, like literally 2 weeks ago, was using AI to pitch my like verbiage. I'm literally like telling the AI, I'm like, hey, I want you to pretend like you're a patient sitting in my chair and we're talking about your meibomian glands. And I see photos on my computer that are showing atrophy. And I set up this whole scenario, and I was like, I want you to listen to what I'm about to say and see if it's understandable. Like, where should I scale it down? Following some of the Story Brand like techniques. Yes. Where should I adjust what I'm saying? Because I only want this to be 20 seconds, 30 seconds long. And then I want them to get all the information. So we've been like utilizing AI to try and train us a little bit to be like, where am I doing this incorrectly? So I think that's been a really neat way of it bringing it. Yeah, I like it.
What'd you learn? What'd you learn from that?
Yeah, so you have to be very thorough in like how you want to set this up. But it knows, and we've done, like, I've used our AI, like ChatGPT, to do like brochures, and it knows all the instruments that we have in the exam. So it's learning as I'm building all these things, and it just keeps telling me to like tailor it to be shorter.
Mhm.
And then it'll give me recommendations. It's like, try saying this instead of saying like what you said.
Right.
And then it's me just trying to like fit that in, because every patient is different. You know,
Yes.
you do see the person that's just like, tell me what I need done. And sometimes those are the comprehensive routine eye exam ones. I'm like, you need this? They're like, I'll be here tomorrow.
Yeah.
And then sometimes they need the ocular surface evaluation and 6 months of follow-up before they ever want to do anything in here. So that's the beauty of the art.
Well, first of all, congratulations. I love that you're reading, keeping up to date, with everything. I know it's so busy as an optometrist. So I love Story Brand, Don Miller. I've seen him speak like 2 times. A lot of the stuff we do at Hoot uses his psychology and his foundation, which is the doctor, the hero, we are the guide. And, the other thing I love about Don Miller is that, he says about the brain, it just wants to consume, the fewest calories possible to understand stuff. So don't confuse, you lose, right? But, the other thing I think is really interesting is that dialogue between you and the patient. And I love that you've done that. So thank you for that. Congratulations for that. And you're really you're on the cutting edge of helping yourself and build your practice and get yourself better. I love it when people are into personal development, because it's really important. As you're an expert, you're like, I want to get better. I want to get better. So it's really important to be open to receiving. So as we wrap up, Dr. Holland, give 2 or 3 pieces of advice for other doctors who wish to grow their specialty care clinic. So what is the 3 things you wish you would have done sooner that you think that people who are doctors, who want to earn more money, help more patients, and really build a better quality of life for themselves? What should they do? Give us the three things.
Use what you have. I don't feel like you need to buy something all the time. I feel like if you have an instrument already, let's build upon that. Because someone's always be knocking on the door and saying like, buy this new thing, buy this new thing, buy this new thing. So like, start with what you have and expand on that. Listen to actually what the patient is telling you. What is their complaint that they're coming in with? Don't forget that. My eyes burn when they're on the computer, or my vision's fluctuated. Like, whatever their leading complaint is, things get better, and then they forget that complaint was now successfully treated because something new or something has popped up. So remember, keep going back to this is the problem. This is the problem. This is the problem. This diagnosis is going to help this problem. This treatment to this diagnosis is going to help this problem. Keep reiterating the one thing that they want to get better, because and verbally say what is the one thing yesterday, the day before that has been bothering you, and get them to say that out loud. Because if they don't even know, because they're just like, I don't know, my eyes hurt, you don't have anything to go back to. So find that one complaint, use what you have. And I would say, sit down and make a tree, like a dialogue tree of how you're going to do this. So if you're going to get them into the ocular surface evaluation, how are you talking about that? Because there can be major points that you need to hit, even though all the patients are different. I need to review my meibography, then look at the image, and then tell them what's wrong. Actually go through that. And I like to just set myself goals. I want to have 5 of these conversations today. And it'll just make sure that I actually do that instead of just forget about it or whatever. So create a tree of how do you get somebody from the comprehensive exam into an ocular surface evaluation? What is your flow? And when does it fit? Before slit lamp, after slit lamp, before optical conversation, after optical conversation? Because sometimes you get to the end of your exam, you're like, shoot, I just talked about all that, and now I have to go back and talk about the glands. So try to figure that out. So create your tree, use what you have, and make sure you stick to your chief complaint.
Yeah, I love this journey. It's this patient experience journey. And, so I think that's really powerful. It's okay, what happens from the time they come in to the time they leave and they sign up, or if they don't sign up? But even what happens if they don't sign up, what happens next? So I think understanding that is very critical. Thank you, Dr. Holland. This has been really fascinating. I love it. I love what you're doing. I love that you're always improving. Because I do remember last year, you're like, I nailed it in the comprehensive, Bob.
You're right, Bob.
I'm shocked to hear you say that. I'm slowing it down. I mean, we talked about this ocular surface evaluation. We talked about that. But I think the world of you. I think, and you and Dr. Wesley, constantly innovating, thinking about how to improve the patient experience and really growing your business. So congratulations for what you're built and what you're continuing to build, because it's never over. It's like you're constantly doing it.
That's the exciting part.
Yeah. So thank you so much for your time and your experience and insights with us. Love to help you in any way further. And as you grow, I'd love to have you and Dr. Wesley back, maybe another conversation about a practice tips and advice. But I want to thank you very much for your time. Have a great rest of the day. Appreciate it.
Thank you, Bob.
Thank you very much. Bye, everyone. This is Bob Miglani. Check us out more on gethoot.com. Thank you for joining us today. For those of you who are watching this live, thank you for joining us live. For those of you watching it at home, check it out. Give us a call if you have any questions. We'll look forward to speaking to you soon. Thank you very much, everybody. Bye-bye.